Hello and welcome to this cardiology module, Approach to Syncope. By the end of this module, you should be able to define what is syncope, identify the different classifications of syncope, understand how and why syncope occurs, delineate a diagnostic approach to syncope, and finally outline the management strategies for patients who experience syncope. Let's get started. So, what is syncope? The term syncope comes from the ancient Greek term syncope, which means sudden loss of strength. Syncope is defined as transient and abrupt loss of consciousness with complete return to pre-existing neurologic function. This definition excludes seizures, coma, shock, and other states of altered consciousness. Syncope is classified as cardiac syncope, neurally mediated or reflex syncope, and orthostatic syncope. These three large categories will be elaborated individually as we carry on in this module. Let's begin with cardiac causes. Cardiac syncope occurs when there is a significant reduction in blood flow to perfuse the brain. This leads to cerebral dysfunction or altered consciousness. Cardiac syncope may be due to vascular diseases, arrhythmias, cardiomyopathies, or structural heart disease such as valvular dysfunction. Vascular disease such as an atherosclerotic plaque causing coronary artery occlusion may lead to myocardial ischemia. Ischemia or infarct can decrease the myocardial function, leading to a reduction of cardiac output causing immediate cerebral hypoperfusion. This is an important cause of syncope to exclude. Arrhythmias. Arrhythmias may include bradyarrhythmias, supraventricular tachyarrhythmias, ventricular tachyarrhythmias, prolonged QT interval, pacemaker dysfunction, and Brugada syndrome. These conditions may lead to significant reduction of cerebral blood flow leading to syncopal events. Cardiomyopathies in specific obstructive cardiomyopathy, in the case of hypertrophic cardiomyopathy, may cause cardiac outflow obstruction and result in sudden onset syncope. One should also consider structural heart diseases which may also lead to cardiac outflow obstruction, for instance in aortic stenosis and pulmonary stenosis. Before we move on to the next cause of syncope, be reminded that an ECG is very important to pick up cardiac causes of syncope as described in this slide. Next, neurally mediated or reflex causes of syncope. In this disorder, an autonomic dysregulation takes place which results in hypotension, bradycardia, and transient loss of consciousness. Reflex syncope may be due to carotid sinus hyposensitivity. Carotid sinus hypersensitivity is an exaggerated response to carotid sinus baroreceptor stimulation. It results in dizziness or syncope from transient diminished cerebral perfusion. Although baroreceptor function usually diminishes with age, some people experience hypersensitive carotid baroreflexes. Vasovagal syncope. Vasovagal syncope is the most common type in young adults but can occur at any age. It usually occurs in a standing position and is precipitated by fear, emotional stress, or pain. Autonomic symptoms are predominant. Classically, nausea, diaphoresis, fading or graying out of vision, epigastric discomfort, and lightheadedness precedes syncope by a few minutes. The syncope is thought to occur secondary to efferent vasodepressor reflexes, resulting in decreased peripheral vascular resistance. It is not life-threatening and occurs sporadically. Another neurally mediated cause of syncope is situational syncope. Situational syncope is a reproducible vasovagal syncope with a known precipitant. For example, micturition, defecation, deglutition, and tussif are types of situational syncope. These stimuli result in autonomic reflexes with a vasodepressor response, ultimately leading to transient cerebral hypotension. Orthostatic syncope refers to syncope resulting from a postural decrease in blood pressure. Orthostatic syncope may occur suddenly with no warning or may be preceded by symptoms. Associated symptoms are usually because of cerebral hypoperfusion occurring in the upright position and includes dizziness, feeling faint or nauseated, diaphoresis, or blurred vision. Syncope due to orthostatic hypotension can occur through several mechanisms: primary autonomic failure, secondary autonomic failure, volume depletion, and drugs. Primary failure of the autonomic system can be secondary to multiple sclerosis, multisystem atrophy, Parkinson's disease, and Wernicke's encephalopathy. Secondary autonomic insufficiency can be due to peripheral neuropathy as seen in diabetics, alcoholics, amyloidosis, and vitamin B12 deficiency. Volume depletion due to blood loss, vomiting, diarrhea, and poor oral intake causes orthostatic syncope. Drugs such as alcohol cause orthostatic intolerance, and medications such as vasodilators and antidepressants block orthostatic reflexes. Making a diagnosis. Clearly, a thorough history is required regarding the onset, the preceding events, precipitating factors, and recurrence of syncope. This is then followed by clinical examination looking for presence of cardiac murmurs, irregular heart rhythms, carotid bruit, postural hypotension, signs of Addison's disease, specific neurological deficits, and signs of dehydration. Investigations which can be done include serum glucose, full blood count, serum electrolytes, cardiac enzymes, an ECG, carotid sinus massage as first-line investigation for carotid sinus syncope, head-up tilt table test, which is useful for confirming autonomic dysfunction, electroencephalography or EEG that can be performed at the discretion of a neurologist if seizure is considered as a likely alternative diagnosis, and a cardiac stress test, which is appropriate for patients in whom cardiac syncope is suspected and who have risk factors for coronary atherosclerosis. The treatment of choice for syncope depends on the cause or precipitant of syncope. Treatment can be largely categorized into emergency department care and follow-up consultations. Patients in whom a cause cannot be ascertained in the ED, especially if they have experienced significant trauma, should receive supportive care and monitoring while tests are being done to establish the diagnosis. Once the patient is stabilized, specific workup can be carried out and referral to the respective consultants can be made. Education is key for certain types of syncope, for example, carotid sinus syncope. Patients are instructed to avoid wearing tight collars, to use a razor rather than an electric shaver, and to maintain good hydration status. They should be seen by a cardiologist and be counseled on the possibility of pacemaker placement in the future. Orthostatic syncope treatment also focuses on educating the patient. Patients are advised to avoid postprandial dips in blood pressure and the importance of assuming an upright posture slowly. Cardiac arrhythmia syncope is treated with antiarrhythmic drugs or pacemaker placement. Cardiac outflow obstruction syncope may be treated with beta blockade to decrease outflow obstruction and myocardial workload. Let's recap. The take-home messages from this module are: syncope is defined as a transient, self-limiting loss of consciousness that is followed by spontaneous recovery. And this definition excludes seizures, coma, shock, or other states of altered consciousness. Begin with a complete history taking focusing on the nature of the event and possible precipitating factors. Other important components in the history would also include past medical history, family history, and drug or medication history. Tests that may point to a particular diagnosis are serum glucose, brain imaging, ECG, EEG, and head tilt table tests. Once the investigations are carried out to identify the type or cause of syncope based on the classifications which are cardiac, reflex, or orthostatic. Management is mainly supportive and treating the underlying cause to prevent recurrence. We have now come to the end of this module. Thank you.